Okay, let's unpack this. Navigating the world of mental health treatment, well, it's complex, isn't it? It often involves medication, and understanding how those medications work is a deep dive in itself.
It really is, because our brains are just incredibly intricate.
Exactly. And for many people, medication is a vital part of their treatment, but how it works isn't always obvious.
No, it's about influencing these really complex biological pathways. Getting a handle on the science behind it is, I think, pretty key.
And that's exactly what we're aiming for today. We've been digging into some source material specifically, bits from a nursing textbook and related slides all about the pharmacology of antidepressants and anxiolytics.
Right, so this deep dive is basically your guide through that material.
Yeah, we want to pull out the most important stuff, how these different drug types work, what they're used for, and really importantly, what the sources flag as key things to watch out for. Side effects, interactions, that sort of thing.
And we're sticking strictly to what's in these sources, guiding you through how these, well, powerful tools interact with the brain and the body.
Okay, so to really get how these drugs work, we need to start with the absolute basics of brain communication, as laid out in these sources.
Right, so you've got nerve cells, neurons, and they talk to each other using chemical messengers, neurotransmitters. The material really focuses on serotonin, norepinephrine, or NE, and dopamine, especially regarding mood and anxiety.
And this chemical chat happens in that tiny gap between neurons, the synapse.
Exactly. The sending neuron releases these chemicals, they float across, bind to the receiving neuron, pass the message on. But then there's a cleanup process.
Reuptake.
Yeah, the sending neuron can basically suck those neurotransmitters back up, reabsorb them.
And that's where a lot of these medications come in, right? The sources say a main mechanism is blocking that reuptake.
Precisely. You block the cleanup crew, you leave more neurotransmitters hanging around in the synapse for longer.
Which potentially boosts its effect. The material kind of illustrates this, like stopping a vacuum cleaner, so there's more stuff left on the floor.
It's a good analogy. And the sources mention another way, too. Blocking enzymes.
Like monoamine oxidase, MAO.
That's the one. These enzymes normally break down neurotransmitters. So if you inhibit the enzyme, less breakdown occurs, and again, more neurotransmitters available.
Okay, so why are these mechanisms important? The sources mentioned the monoamine hypothesis.
Right. The idea that maybe deficiencies or imbalances in these chemicals are linked to things like depression. But, and this is a key point in the material, there isn't really clear evidence that just measuring a deficiency explains depression itself.
So it's more complicated than just low levels.
It seems so. The sources hint that the real effectiveness might involve slower processes. Downstream molecular events, they call them.
Like what?
Well, maybe receptors becoming more sensitive over time if levels have been low upregulation, they call it. That could explain why it often takes weeks for these meds to really kick in,
Okay, that makes sense.
Or even things like affecting the birth of new neurons, neurogenesis, maybe the hippocampus.
Wow, so it goes way beyond just the immediate chemical levels in the synapse.
It certainly suggests a deeper complexity, which the sources acknowledge.
Okay, so with that basic understanding, let's dive into the actual antidepressant classes. The sources group them by how they work, their mechanism.
Right.
Kicking us off, the selective serotonin reuptake inhibitors, SSRIs, very widely used.
Yeah, hugely common. And like the name says, they mainly block the reuptake of just serotonin.
Examples listed are things like fluoxetine, Prozac, sertraline, Zoloft, paroxetine, Paxil.
Citalopram, Celexa, acetylloxacine, Lexapro, fluvoxamine, vilazodone, a fair few.
So boosting serotonin is the goal. What about common side effects the material points out for this class?
Well, they list things like anxiety or restlessness, agitation, maybe akathisia, that feeling of inner restlessness. Nausea is common too, but often temporary.
Okay.
Also, insomnia, sexual dysfunction, and potential weight gain are noted. Less often, maybe sedation, sweating, diarrhea, or hand tremor.
We mentioned the delay in effect, possibly due to receptor changes, but what's a really critical safety warning the sources emphasize with SSRIs, especially if mixed with other things?
Yes. Serotonin toxicity, or serotonin syndrome. The sources flag this as potentially life-threatening. It happens when there's just too much serotonin activity going on.
And the risk is higher.
Particularly high risk if combined with MAOIs, but also other drugs that affect serotonin.
And the symptoms sound quite specific. The material says you need at least 3 for a diagnosis.
Right. Things like agitation, ataxia that's impaired coordination, sweating, diarrhea, overactive reflexes,
Hyperreflexia, yeah.
mental status changes, muscle twitching or myoclonus, shivering, tremor, and even hyperthermia, a high body temperature.
Definitely something to be aware of.
Absolutely. Now, the selectivity of SSRIs is generally a plus fewer side effects than older drugs because they mostly target serotonin. But like you said, too much serotonin is still a risk.
And the sources also mention withdrawal issues, discontinuation syndrome.
Yes, especially with SSRIs or SNRIs that have a short half-life. Stopping them too abruptly can cause problems.
Okay. And drug interactions, too, because of how they're processed in the liver.
Right, the CYP450 enzyme system. The sources mention things that inhibit a specific enzyme, CYP3A4, can increase SSRI levels, while things that induce it can decrease them.
Got it. And they briefly touch on newer agents, like vortioxetine, having maybe more complex actions.
Yeah, multimodal activity, not just reuptake blocking, but maybe directly interacting with different serotonin receptors, too.
Okay. So moving on from just serotonin, norepinephrine reuptake inhibitors, SNRIs, what's the key difference here?
Well, as the name suggests, these block the reuptake of both serotonin and norepinephrine.
Examples like venlafaxine Effexor, duloxetine Cymbalta.
Desvenlafaxine Pristique, levomilnacipran, Fetsema. The sources note they're good for depression, but also often used for anxiety and even neuropathic pain.
Okay, interesting. Now, let's step back to an older class, the tricyclic antidepressants, TCAs. What's their main action according to the sources?
They primarily block norepinephrine reuptake and serotonin reuptake to a lesser degree. The sources also mention they block MAO activity.
The material calls them dirty drugs sometimes. Why is that?
Basically because they're not very selective. They hit the reuptake pump, sure, but they also mess with several other receptor types.
Which explains the pretty long list of side effects in the sources, especially those anticholinergic ones.
Exactly. Blocking acetylcholine receptors leads to dry mouth, fast heart rate, constipation, trouble urinating, dry nose, blurred vision.
Yeah.
And in older adults, it can even cause agitation, delirium, or a serious bowel issue called ileus. Plus, the sources list other big ones: orthostatic hypotension, dizziness on standing sedation, weight gain, sexual dysfunction.
And I see the sources highlight a very serious risk: overdose potential.
Yes, they're more easily absorbed and stored in fat, which makes overdose potentially fatal, more so than with some newer drugs.
Okay, definitely important considerations. Now, a class with some really critical safety warnings. The monoamine oxidase inhibitors, MAOIs, mechanism first.
These block that enzyme, MAO, which normally breaks down monoamines like norepinephrine, serotonin, and dopamine. So blocking the enzyme leaves more of these neurotransmitters around.
Examples: phenelzine, Nardil, tranylcypromine, Parnit, and the selegiline patch, MSM. And the sources are crystal clear. The major risk is hypertensive crisis.
Absolutely non-negotiable point. The material spells out that this is triggered by interactions with specific foods and medications.
The food list is quite detailed. Aged cheeses, cured meats.
Fermented things like beer, wine, sauerkraut, soy sauce, yeast, MSG, basically anything with high levels of tyramine.
And certain medications, too.
Yes, things like pseudoephedrine in cold meds, St. John's wort, other antidepressants, buspirone, even cough medicine with dextromethorphan, and the painkiller meperidine. It requires very careful management.
It really sounds like it. And the symptoms of this crisis.
Severe headache, chest pain, fast heart rate, shortness of breath, really high blood pressure, sweating, anxiety, confusion, high fever. It's a medical emergency.
Okay, so those are the big older classes. The sources then briefly mention a few others.
Right. There are norepinephrine dopamine reuptake inhibitors, or NDRIs. Bupropion, or Butrin is the main one.
And it blocks NE and dopamine reuptake, but not serotonin.
Correct, which is why it sometimes has fewer sexual side effects. The sources also note it hits nicotinic receptors, hence its use for smoking cessation as Zyban.
Then serotonin norepinephrine disinhibitors, SNDIs, like mirtazapine, Remeron. How does that work?
It's a bit different. It blocks certain receptors on the sending neuron, called alpha-2 receptors, which actually causes more NE and serotonin to be released. The sources say it's often used alongside SSRIs.
Interesting. And serotonin antagonist reuptake inhibitors, Hecruris, like trazodone.
Yeah, trazodone, Desirol. The sources say high doses are needed for the antidepressant effect, but lower doses are commonly used for sleep.
Why for sleep?
Because at lower doses, its effect on histamine receptors is more prominent, causing sedation. A specific risk mentioned, though rare, is priapism.
Right. And lastly, selective norepinephrine reuptake inhibitors, NRIs.
Like atomoxetine Strattera. Blocks any reuptake, but the material points out it's mainly used for ADHD, not typically depression.
Okay, wow. That gives us a really solid map of the antidepressant landscape based on these sources. Lots of different approaches.
Definitely. Varied mechanisms, different risks, different uses.
So now let's switch gears slightly to anxiolytics meds for anxiety. Although, as the sources noted, some antidepressants we just talked about, like SSRIs and SNRIs, are very commonly used for anxiety too.
True. But the main class discussed specifically as anxiolytics in the material is the benzodiazepines, benzos.
And these are controlled substances, Schedule 4.
Right. Their mechanism, according to the sources, is binding to GABA-A receptors. GABA is the brain's main inhibitory neurotransmitter. Benzos basically boost GABA's inhibitory effect.
So they calm things down, but they need GABA there to work.
Exactly. They enhance GABA's natural action. They don't work without it.
And the list of examples is long. Diazepam, Valium, lorazepam, Ativan, alprazolam, Xanax.
Clonopin, oxazepam, Cerax, temazepam, Restoral for sleep, chlordiazepoxide, Librium, often for withdrawal, many others too.
The sources mentioned their use might be decreasing for long-term stuff due to risk.
Yeah, there's a trend away from long-term use, but they still have a definite role for acute situations. Severe anxiety, panic attacks, muscle spasms, sometimes insomnia, alcohol withdrawal protocols, and seizure control.
But the risks,
Yeah.
the sources seem very clear on those.
Extremely clear. High potential for abuse and dependence. Dependence can develop quite quickly, apparently. And withdrawal after long-term use can be dangerous, even fatal, if stopped abruptly.
And they can sometimes make agitation worse, paradoxical agitation.
Yes, that can happen.
What about the more common side effects listed in the material?
Sedation and fatigue are big ones. Poor coordination, ataxia. The sources link this to GABA receptors in the cerebellum. Memory impairment, specifically forming new memories.
And tarot-grade amnesia.
Right. Confusion, dizziness, slurred speech, muscle weakness, low blood pressure, and importantly, slowed or shallow breathing.
Those sound pretty significant, especially, say, for older adults.
Definitely. The sources list serious potential side effects like significant CNS and respiratory depression, rare liver or kidney problems, blood count issues, and they specifically call out the increased fall risk in the elderly, plus potential psychosis or agitation.
So given all that, what are the key teaching points the material emphasizes for patients?
Well, first, that they help symptoms but don't fix the underlying cause. The sources use the term Band-Aid.
Okay.
Critically,
Yeah.
do not mix with alcohol or other things that depress the central nervous system. That's a huge warning.
Right.
Also, they slow reaction time and reflexes, cause sedation, so no driving or operating machinery. And the point about not stopping abruptly is repeated. It's dangerous.
Makes sense. The sources also mention another anxiolytic, buspirone. Busbar. How's that different from benzos?
Its mechanism is different. It mainly targets a specific type of serotonin receptor, the 5-HT1A receptor.
And the benefit?
The sources say it reduces anxiety without causing that immediate sedation or the euphoric feeling some get from benzos. This means it has a much lower potential for addiction or abuse.
Interesting.
Yeah, the material actually considers it pharmacologically closer to an antidepressant than a typical benzo.
And finally, the sources just list a few other medication types sometimes used for anxiety symptoms.
Right, things like beta blockers, propranolol being an example, antihistamines like hydroxyzine, and even alpha blockers like prazosin or clonidine.
Okay. So that covers the main drug classes and how they work, according to the material. But the sources also briefly link this to some bigger ideas, right?
Yeah, they touch on psychoneuroimmunology, or PNI, which
Yeah.
they describe as the field looking at the links between, well, the immune system, the nervous system, behavior, and health.
And they mention inflammation.
That chronic inflammation and certain immune messengers, cytokines, seem to be linked to some psychiatric disorders.
Which leads to neuroimmunopharmacology.
Right. Research into drugs that might actually target those neuroimmune processes.
It really just underscores the complexity the sources highlight throughout, doesn't it? Treating mental health isn't just about brain chemistry in isolation.
Not at all. You're influencing brain activity, sure, but the effects ripple outwards. And the material acknowledge genetics playing a role in how people respond, how systems are regulated.
And the development of new drugs is ongoing, always trying to get better efficacy, better safety, fewer side effects.
Aiming for more targeted action, basically.
Which brings us back to why understanding those potential undesired effects listed in the sources is so important. Sedation, agitation, motor issues, those anticholinergic effects from TCAs, sexual sexual dysfunction, weight gain.
Yeah, these aren't just minor footnotes. The sources make it clear there are major factors in managing treatment effectively, balancing the good the drug can do against these potential downsides.
Absolutely. It's a constant balancing act.
It really is.
So that wraps up our deep dive into the pharmacology of antidepressants and anxiolytics, working through this nursing textbook material. We've gone from the synapse, the basic mechanisms like reuptake and enzyme inhibition.
Through the details of major classes like SSRIs, SNRIs, TCAs, MAOIs, and benzos, covering their actions, uses, and those really critical risks, like serotonin syndrome and hypertensive crisis.
And we also touched on that broader context. The sources provide the links between body systems, the ongoing evolution of treatment.
Yeah, trying to understand how we treat these conditions pharmacologically.
Our goal was really to give you a clear, source-based picture of these important medications, appreciating their power, but also the complexities and cautions involved in using them.
And thinking about that ongoing search for better, safer, more targeted drugs,
Yeah.
it really makes you consider the immense challenge, doesn't it? Trying to fine-tune something as complex as the human brain and body.
It really does. How do we keep refining these powerful tools, understanding both their potential and their limits, especially as we learn more and more about that intricate mind-body
Right.
connection? That's
Mhm.
definitely something to keep thinking about.